Every oral and maxillofacial surgeon should be comfortable managing a patient's airway and be prepared to take control of an airway in an emergency situation. Some patients may present with factors that make their airway difficult to secure. Those factors should be considered prior to providing anesthesia. There are a multitude of anatomic factors that should be considered when evaluating the airway. Examination of the patient's head and neck may reveal a short, thick neck with limited range of motion, a retrognathic mandible, a large tongue, or large tonsils, among other anatomic findings. All of those may prove to make airway management difficult. The Mallampati airway classification is useful in assessing possible difficulties. Consideration should be given to, but not limited to, difficulties that may be encountered ventilating the patient. These may include intubating the patient, gaining cooperation from the patient for adjunctive airway management procedures, and lastly, creating a surgical airway.
Dr. Shinley, her stats are starting to drop.
Yeah, they are. Okay. Try and reposition her jaw, Sue.
In this case, the team is providing anesthesia for a non-intubated patient who is breathing spontaneously. The team notes some difficulty in respiration, and the chin lift jaw thrust maneuver does not resolve the issue.
This doesn't seem to be making much of a difference. Let's see if I can pull her tongue forward.
89, 86. I don't hear any breath sounds.
Okay, let's go ahead and switch over to a full face mask. And I'm going
The tongue is protruded by means of traction, but this maneuver does not resolve the airway obstruction. Continued airway obstruction, despite these maneuvers, usually requires the use of mechanical airway opening devices. Positive pressure ventilation with a bag mask device is deployed. If the patient becomes hypoxemic or fails to make respiratory effort, an oral pharyngeal or nasopharyngeal airway should be used in conjunction with bag mask ventilation. The attempt to ventilate the patient with these devices fails. An attempt is made at this point to establish an airway by insertion of a laryngeal mask airway, or LMA.
Chest rise, I don't think we're adequately ventilating this patient. That's placed a supraglottic airway. Would you give me an LMA, please?
Note, insertion of an LMA is not appropriate when the airway obstruction is due to a foreign body, vomiting or aspiration, or if there is airway edema.
I'm not getting a chest rise and I'm hearing a leak. I'm going to reposition the LMA. Can you take the cuff down?
Should an LMA be ineffective in securing an airway, consider endotracheal intubation with a laryngoscope and direct
Still
laryngoscopy.
no chest rise. I'm not getting through. Let's prepare to intubate the patient. Take the cuff down.
The surgeon may choose the laryngoscope blade he or she is most comfortable with, but should have multiple sizes available.
Okay, tube's in. Take the stylet. I still don't see any chest rise. Do you hear breath sounds?
There's no breath sounds.
Okay, let's prepare for a surgical airway. Please get the cricothyrotomy kit.
After 1 to 3 unsuccessful attempts to intubate the patient, consider a surgical airway. A cricothyroidotomy or tracheostomy can be rapidly completed in an emergency situation.
Okay, let's slowly pull the ET tube as I'm introducing. Introduce it. There's the cuff up. Let's hook up the bag. I see chest rise. Do you hear bilateral breath sounds?
Equal breath sounds bilaterally. Sounds good.
Secure the tube
Let's
and
secure
your passport.
the tube.
Okay.
Airway obstruction summary. Treatment of non-intubated patient. Stepwise interventions until successful ventilation. Chin lift jaw thrust maneuver. Pull tongue forward and reposition airway. Positive pressure ventilation with bag mask. Consider oral or nasal airway. Consider placement of LMA or other adjunct airway devices. Attempt endotracheal intubation with laryngoscope, mask ventilation intermittently. Consider surgical airway